Morning, everyone. Go ahead and get started. As people maybe join and Zoom is allowing them in, I'll just start with an introduction of Karl and Steinlage Insurance Agency, who's partnering with us for this webinar. This is a really relevant topic for you. If you're new to Medicare, you've got an upcoming 65th birthday, perhaps you're retiring, you're considering retirement, and you're over 65. If you're currently on Medicare, we know Karl's team is available and willing to help. They're experts in the Medicare planning industry, what can be a very complex market. And so we've really appreciated the flexibility and also just their ability to respond very quickly to questions. They don't consider any of the questions to be silly or bad questions, and honestly, they've done a really great job of making life easier and less complicated for the majority of the clients that we send to them. And let's be honest, they've done a really good job of saving hundreds, if not thousands, of dollars a year for their clients. So we're grateful for Karl to join us. A little bit about Steinlage Insurance Agency. It's a family-owned and operated business since 1950. So been around for a long time. They do pride themselves on being nationally recognized as a leader in the Medicare insurance brokerage industry. They are headquartered here in St. Louis, and Karl happens to be the co-owner and CEO of that. A little background of Karl. Karl's got a bachelor's degree from St. Louis University, where he played baseball as well. And then he went on and received his MBA from St. Louis University. He is a dedicated husband and father, and I have played golf with him, but I've also told he likes to enjoy basketball, soccer, and baseball. Karl, one of the things I'm really interested in learning more about is the changes, whether those are intended or unintended changes that came out of the Inflation Reduction Act that Congress passed back in August of 2022. I know that has created more complexity. And so I'm sure you'll be addressing a little bit of that. So yeah, that's one of the things I don't know if excited is the word, but most interested in learning more about. So
yeah, excited is probably not the correct word to use, but just curious on what's going to happen. So
curious on those unintended consequences of kind of new legislation. So welcome to the webinar, Karl.
Yeah, thanks for having me again. I think we're well past double digits as far as the years that we've done this. So time marches on. I think I probably need to update my bio because my basketball playing days and my baseball playing days recreationally I'm fully retired from that. So I'll see if I can tweak the intro a little bit. But I think this webinar, we were kind of talking about just how we're going to format it. And I think we'll spend a little bit less time on how we get into Medicare and more time on some of the changes in the upcoming annual enrollment period. So if anybody listening is kind of pre-Medicare, maybe you're thinking of retiring and you're over 65 or aging into Medicare, turning 65 in the next year, I would encourage you to just reach out to have a quick conversation and make sure that you are kind of preparing correctly for your unique situation. The ideal time to have a conversation with us, I would say, is around 3 to 5 months before that birthday or targeted retirement date. So you have plenty of time to kind of get your ducks in a row and learn about the different plans that are out there. So we'll touch briefly on what is Medicare and kind of the intro into it, and then we'll focus the rest of the webinar on some of the changes coming up. So Medicare, we call this, health insurance from the federal government. So when we talk about enrolling into Medicare, we're really talking about one of three things. One is we may recommend somebody do absolutely nothing when they turn 65. We may recommend that somebody takes the free part of Medicare, which is called Part A only, or we may recommend that somebody moves all the way into Medicare and completing Part A and Part B. And Part A doesn't have a monthly premium. Part B carries a monthly premium that changes every year. This year, the premium's $174.70. We don't have 2025 rates. We don't have the 2025 IRMA in brackets. And we also don't know what the 2025 Social Security cost of living adjustment is yet, as those are usually out by now. But I think with an election year, everything's just kind of being held a little closer to the chest. So based off of your specific situation, one of these three paths is what you'll end up doing when you're turning 65. And so depending on whether you have a health savings account, depending on the price of your employer plan, or whether you're working or retired, that will kind of dictate which door makes the most sense for you to go through. And this is where I would encourage you to reach out to me. There's so many nuances and specific variables that are unique to everyone's situation that will dictate what makes the most sense. But we'll just hit on a couple of kind of common scenarios we see. If you are working full-time for a large employer and you have health insurance through that employer, or you're the spouse of somebody working for a large employer, and large is deemed 20 or more employees. So if I work for somebody that has more than 20 employees, there are no penalties if I delay Medicare. We hear that quite a bit, where people think they have to do something at 65 to avoid having penalties show up when they re-enter Medicare upon retirement. And that simply is not the case. So clients that would go through door number one would be funding a health savings account, because if you delay both parts of Medicare, the free part, Part A only, and Part B, and you remain on that employer-sponsored plan, you can continue to fund that HSA for as long as you do not have Part A in effect. So if we're on an employer plan, we're funding the HSA, oftentimes the right thing to do is just absolutely nothing. If we're on a PPO style plan where we have copays at the doctor, maybe a much lower deductible, then the right advice might be to just take Part A only. So in that situation, we don't have an HSA to worry about, and we are still going to stay on that group plan. We've identified that the group plan is a better deal. It's a lower premium, a lower deductible. Maybe it's expensive, but you have a younger spouse and children on your plan, to where if you dropped off of your group insurance to move into door number 3, all the way into Medicare, you would find that your spouse and kids would have to go buy Cobra or Obamacare, and it just wouldn't make sense to take you off of the group plan. So in that situation, oftentimes we would recommend that somebody just gets their foot in the door. They kind of take the free part, which is Part A only. That would generate a Medicare card and a Medicare number. So now we're kind of ready to go later on in life when you do retire and move all the way through door number 3. So door number 3 is what we refer to as signing up for Medicare. And then we're going to explore some of these extra plans like Medicare supplements and Medicare Advantage plans. So if you are working full time, I would never make the assumption that your group plan is a better deal than Medicare. We have seen so many changes in the employer market, oftentimes for the worse. We've seen rates go up for employees. We've seen deductibles increase. So oftentimes people are sure they're not going to do anything with Medicare, but when we dig a little bit deeper and we find that you're paying $400 a month for your group plan and it has a really high deductible, then Medicare can look like a better deal. It can be a lower premium for better coverage. So we help clients make that analysis of, should I take my group plan or should I move to Medicare? Or if you are not on an employer plan with more than 20 employees, so if it's less than 20 lives, then we have coordination of benefit rules that say that Medicare actually has to be primary, and so you're forced to move into Medicare. Or if we're on Marketplace, whether we're getting subsidies or not, we're on COBRA, we're uninsured, or we're on retiree healthcare, then you have to take Medicare. I would say one of the most common mistakes we see people make in that situation is if you are on a subsidized COBRA benefit. We saw this a lot through COVID, where people were let go, and part of their severance package was the employer paid 6 months of COBRA premium. And you thought you were on a group plan, but you actually weren't. Those clients needed to move to Medicare A and B right at that time to avoid penalties. So when we talk about turning 65, there's really 3 options to select. And then we also need to be mindful of HSAs and a 6-month look back on Part A. So if I am 65 and I delay all parts of Medicare, and then I continue to fund my HSA at 65, 66, 67, and then I retire, you have to be conscious of funding the HSA in that last year of retirement, because once you start to chip away at getting into Medicare, your Part A effective date, which determines your eligibility to fund the HSA, will start 6 months prior to when you enroll. So an example of a client retiring in October of next year, they may have fully funded their HSA for 2025. Let's say they put all of the money in January 1st, 25. Now they reach out to us, ideally 3 or 4 months before this date, so we have enough time to get everything ready to go. And their first step is in July. They need to enroll into Part A. Well, because of that 6-month look back, they're going to get an effective date of 1/1/25. So if they had fully funded that HSA in 25, they need to back that funding out because of that 6-month look back. So key takeaway here is HSAs are awesome. We write and endorse them and encourage people to take them through employer plans. But as you get closer to retirement or Medicare eligibility, or even drawing Social Security, because when you draw a Social Security benefit of any kind, your Part A automatically starts. So we just need to be aware of Part A and HSA opportunities. So then we transition into, if I am getting fully into Medicare because I'm on retiree coverage or I'm on Obamacare and I'm turning 65, there's 2 ways to sign up for Medicare. One's an automatic enrollment if I'm drawing a Social Security benefit prior to 65. The other is if I'm not drawing Social Security, then I need to proactively enroll into Medicare through my ssa.gov portal. And so that can get tricky because the government has actually changed the login requirements, hopefully for the last time, but here in the last few weeks, they transitioned everybody into what's called login.gov. And I think a lot of people, if we're already on Medicare and you have an ssa.gov account, you probably got a lot of emails talking about converting your account to this more secure login. But what we're finding is that anytime the government shifts the rules on this, people get locked out. And so I would encourage anybody not on Medicare yet, approaching 65, or maybe retiring soon, let's make sure that you can log into ssa.gov. You don't have to do anything else, but let's just make sure that you're not locked out of that account. Because if you are, that can be a 2 to 4 week process to wait for a PIN number to be mailed to you. And that can really put some stress on that timeline if we have to wait a month or 2 for the government to send this PIN number out. So we want to get that taken care of. And then if you have one of these unique situations, I would encourage you to just give yourself extra time to sign up for Medicare. What we're seeing is that Medicare and Social Security are still short-staffed, and so wait times, normally are 3 to 5 weeks, and now we're seeing sometimes that take 6 to 8 weeks, depending on the scenario, and then that gets even worse at the end of the year because of this large traffic jam of people retiring at the end of the year, and then the annual enrollment period adding extra people kind of shopping around and making phone calls and whatnot. So when we talk about moving into Medicare, we talk about Part A, which is free, and Part B, which carries a monthly premium. And then that Part B premium has a means test associated with it called IRMA, Income Related Monthly Adjusted Amount. So IRMA is a means test on your Medicare premiums. If you make more money than a threshold, then the government will raise your Medicare premium. And it is a 2-year look back. So clients that are already on Medicare today, the price that they are paying for Medicare in 2024 is the standard fee, $174.70 for Part B. So that comes out of your Social Security check. If you're not drawing Social Security, because we're going to take Medicare at 65, but delay Social until 70, then you get invoiced that Medicare premium on a quarterly basis. So you get a bill in the mail, but then they look back at your income from 2 years prior. So your 2022 adjusted gross income, or household modified adjusted gross income, that determines your rate for 2024. And if you're married filing jointly, here are the different brackets. And if you file a single return, here are the different brackets. So as we move into 25, clients that are already on Medicare will see a change in their Medicare premium because the base rate changes every year. We're projecting this to be somewhere around about 185 for next year. And then they will look back at your income in 2023. So if you had low income in 22 and had no IRMA assessment, and then your income was higher in 23 because of investment gains, the sale of property, deferred compensation, Social Security turned on, whatever it is, the government will then assess that fee in the mail sometime around Christmas and add that extra fee onto your base premium starting in 2025. So the opportunity here is that if you had a recent life event, by far the most common one is work stoppage or work reduction that has caused your income to drop from 22 or 23 into 2025, then you can actually appeal IRMA and you can ask the government for a redetermination saying, hey, don't use 2023. I was working full-time then. Now my income is much less. Use 2024 or 2025, and that will allow you to estimate your income and potentially drop your IRMA surcharge. So as we carry that forward, that is what I would label original Medicare. So when we talk about, what is Medicare, is that enough? Understand it this way, that Medicare on average pays 80% for hospital and medical services. So everybody on Medicare, right? All roads kind of lead to Medicare. We are paying some monthly premium that ranges between about $175 and $700 a month per person, depending on our income. That goes to the government. And what we get for that is we get 80% coverage for hospital and medical services. And so that leaves behind some gaps that private insurance companies fill. And that's what we sell as an agency. Those companies pay us commissions, but that is what people buy to do the job properly. Because Medicare by itself, just covering 80%, we have a balance of 20% due with no max out of pocket. So one of the big negatives of just having Medicare A and B is that if you get really sick, that 20% is an unlimited exposure. It could be really low for many years and then really high. It just depends on your health, or it could be really expensive every year if you have a chronic condition. So people buy supplemental insurance, or they opt for what's called Medicare Advantage to solve for the 20%, to solve for prescription coverage, and to solve for dental and vision. Those are kind of the 3 or 4 areas that are not covered by original Medicare. And so this is the way the market has been for 15, 20 years now, is that as a Medicare beneficiary, the decision you make to solve for those things is really we're picking a path. We're going to buy supplemental, prescription, dental and vision, or we're going to opt for this all-in-one Medicare Advantage. And so our agency, we sell every plan people can buy on both sides of this. Those companies compensate us equally. So we're not incentivized to try to encourage you to go down one side or the other. So the goal is to just make sure that you feel educated on the pros and cons and not miss something obvious or something that is important that might not be obvious because of a benefit that might sound great today but isn't there later on, or some of the rules and limitations between these two. So if we start on the left-hand path, which I would label kind of the Cadillac coverage, right? So this is the most expensive and the most comprehensive setup we can buy on Medicare. So if we do this, what we're doing is we're buying a Medicare supplement from some insurance company, United through AARP, Blue Cross and Blue Shield. Cigna is very competitive in a lot of parts of the country right now. But those supplemental plans all carry a standardized policy. So if you look on your Medicare supplement card, it probably says Plan F, Plan G, Plan N. Those are the most popular plans. And what that does is that transfers the risk of the 20% from you to the insurance company. So you pay a monthly premium. That premium ranges anywhere between about $140 a month to about $200 a month if you're 65. That variance is going to depend on where you live and your gender for the most part. But that supplement wraps around and covers the 20% balance left behind by Medicare. So people really like this setup because they can see any doctor in the country. There's no network restrictions. Right now in St. Louis, we've got this big concern about Anthem, Blue Cross and Blue Shield, and Mercy healthcare systems potentially non-renewing their contract. If you have an Anthem Medicare supplement, that does not affect you. We have had tons of clients reach out to us super concerned with, I can't lose my Mercy doctors. I've got X, Y, and Z happening. And that is the beauty of this side, is that you do not have a network of providers to pay attention to. You are free to see any provider in the country that takes Medicare. So you don't have to change your supplement, because if Mercy takes Medicare, which they do, as well as like 98% of all providers in the country, then they take your supplement, no questions asked. One of the challenges on this side, though, is that Medicare supplement premiums go up every year. So we do see a 5 to 10% increase pretty consistently on Medicare supplement plans. So we're starting at $140, $150 a month, but it is not uncommon as we get older and presumably use this more that the premiums go up. So on this side, that's how you cover the 20%. And then we also add a standalone drug plan to cover prescriptions. And drug plans can range anywhere from, there's a couple that actually don't have a monthly premium, $0 up to maybe 30 to 60. And for the longest time, your drug coverage had something called the donut hole. And so we'll talk about here in a couple of slides how the drug benefit is changing because of this Inflation Reduction Act. And a lot of people that are already on Medicare have probably received their, it's called Annual Notice of Change, or ANOC. That's this document from your current insurance company that says, this is what we did this year. This is what we're doing next year. We're raising the premium. We're adding a deductible. We're changing the copay from $50 to a percentage of the cost of the medicine. But over here, we buy a standalone drug plan. And then if you want dental and vision, we add that separately. Now, for the longest time, there still isn't great dental insurance, but dental wasn't what I don't think I would buy it on myself. So I probably talked a lot of people out of buying dental coverage. And not that the market has gotten so great that you have to buy it, but we've got a couple of plans that now have beefed up their coverage. So if you've had a dental plan just kind of sitting, there and you've used it, now might be a good time to just kind of look at some of these newer plans, because they have much higher caps on what they pay per year. The average up until last year was $1,500. Most dental plans that you bought only paid up to about $1,500. And now we're seeing a lot of plans double that and give you up to $3,000 of coverage for crowns, root canals, implants, that type of stuff. And then we've also got a plan that doesn't have a waiting period. So if anyone listening has been on this path, Medicare supplement drug plan, and you haven't bought dental and you have a crown or a root canal that you need, we can sell you a plan for about $60 a month, and it will immediately pay for those crowns and root canals and extractions. And the only thing that has a waiting period is implants. But that's unique because most plans would make you be in that for a year before they cover those major services. So that's new. And we had a situation probably 8 or 10 years ago where a dental company let us sell it without a waiting period, and that was pretty well received. So this is the Cadillac setup. You go where you want, no networks, no pre-authorizations. And the catch here is that you get one chance to buy the supplement without answering any health questions the first time you get into Medicare. So if we turn 65 or we delay our part A and B because we're on group insurance, and then we move into Medicare later on in life at 70 or 75, whatever it is, that is when our one-time shot to buy the supplement opens up. So if we do this right the first time, and then we delay correctly because we have a competitive group plan, then you maintain that control of being able to buy that Medicare supplement later on in life without answering any health questions. So I would say a lot of our higher income clients that can afford, $150, $30, $60 for a dental and vision, this ends up being without an income adjustment, about $400 per person per month. We have a lot of clients that feel like they can afford that. They travel. They like the idea of no networks, no pre-approvals needed. A lot of people that work in healthcare migrate towards this side because they've seen some of the frustrations of HMOs and PPOs and all these referrals and, doctors leaving networks. All of that is avoided by coming over here, which is why if you have an Anthem supplement, this Mercy concern really doesn't affect you because Medicare is your primary payer. But what we are seeing because of inflation, medical usage, the normalness of having a deductible and a network through group insurance, people new to Medicare, like the younger, 65 coming into this, we are seeing them be more open and receptive to joining a Medicare Advantage plan. So the other way to solve for this is to enroll into a zero premium Medicare Advantage plan. And everyone's probably seen the Joe Namath commercial and the JJ Walker commercial that run all the time on this. We are now starting to get into open enrollment, which is October through December, where the marketing buzz, triples and quadruples. And so what it is that Medicare Advantage is the privately run version of Medicare. So if I sell somebody a Medicare Advantage plan, that plan, for the most part, doesn't charge you any additional premium above and beyond what you pay to Medicare. And what happens behind the scenes is the government subsidizes these programs. And the government is paying these companies anywhere between $10,000 and $20,000 per person per year to manage the Medicare program for you. So if I buy a Medicare Advantage plan, I still have original Medicare. I still have to pay my Part B plus any IRMA surcharges. That's always going to come out of my Social Security check. But then I put that red, white, and blue Medicare card away, right? Over on this side, when I go to the doctor, Medicare is my primary insurance. They pay the 80%. And then that supplement that I'm paying $150 or $180 for, they wrap around and cover the 20%. On a Medicare Advantage plan, the government pays the insurance company to become primary. And so Medicare Advantage, people will refer to it as Part C because they say it combines your A, B, D, and other benefits like dental and vision. So you get prescription coverage included in Medicare Advantage. I like the term replace. Medicare Advantage replaces original Medicare. So if I sign up for Medicare Advantage, I use my United Healthcare HMO or PPO card, my Essence HMO or PPO card, my Anthem HMO or PPO card. And then that private company is my primary insurance. And because the government has paid these companies so much money, that amount of money has gone up meaningfully before, during, and after COVID. So 5 years ago, these plans might have received $8,000 to $14,000 of reimbursement, but now it's gone up. And when that happens, that makes this market look more attractive. If these insurance companies have more money per person to spend, then they give that back to the consumer in the form of dental, vision. We had a plan this year that gave reimbursement for golf clubs, ski tickets, lift tickets, kayaks, like some pretty crazy stuff. But what we're seeing is because of the Inflation Reduction Act, it is targeting that excess funding and taking some of that away. So what we're seeing is kind of this regression. And it's funny, last year I used the same slide, and at the bottom I put plans are getting really, much more attractive for 2024, and that was the case. But now we're starting to see some shift in, attitude towards this. But Medicare Advantage is not good or bad, right or wrong. It's just a different way to solve for those necessary evils: 20% coverage, prescriptions, dental, and vision. So the trade-off is that if I go with Medicare Advantage, I limit my choice. I have a network I have to follow. I have some skin in the game. So a Medicare Advantage plan is going to kind of operate like an employer plan from 30 or 40 years ago. Most of the plans are going to be zero deductible, pay as you go up to a max out of pocket around $4,000 to $5,000 per person per year. So if I had a knee replaced over here, I could see any doctor that takes Medicare and my supplement pays 100%. So I have 100% coverage, and I'll have more wiggle room as far as how much physical therapy I can get. There's less oversight, in my experience, on your healthcare on this side. If I'm on a Medicare Advantage plan, I have to stay in the network, so I need to make sure that surgeon's covered. That procedure has to be pre-authorized by the plan. Most of the time it is, but sometimes there's some friction there. That's one of the negatives over here. And then I pay as I go. And so I might pay a fee for the surgery, a fee for the MRI prior to having the surgery, and then I pay a fee each physical therapy session, maybe a $30 copay. And so at the end of that, that total knee replacement might have been billed at $30,000, but my Advantage plan paid 80% on average, right? Because the Advantage plan is replacing Medicare, and I paid copays that are probably around $1,300 all in on a total knee replacement. And I had to follow the rules of the plan. And so one of the nice things about Medicare Advantage is that it can be a cost-effective solution if you're in good health, because I don't have to pay that Medicare supplement premium. I don't have to pay that prescription premium. And I'll often get some dental and vision included here as a throw-in. So I don't really need to make a decision on whether I want it or not. It just comes with it. But the catch is that if we're on Medicare Advantage and now the plans get worse, or the network changes negatively to where, it was great today, but not so much in the future because doctors leave it, or a healthcare source like Anthem. If you have an Anthem Medicare Advantage plan in Missouri, that negotiation does affect you. Anthem is your primary insurance, and so you would lose access to Mercy providers if you have an Anthem Medicare Advantage plan. So anybody that is concerned of that, if you have Anthem on an Advantage plan, that would be a reason for us to look at maybe switching you. And so the catch is that if you don't like this anymore for whatever reason, and you want to leave it and come back over to the supplement, you have to go through underwriting. We have to disclose your age, your height and weight, your prescription usage, your health history. There's a series of questions. And a lot of times people will wait until it's too late. Advantage is awesome while you're healthy, but then when you get sick, sometimes those limitations can really show themselves on the last leg of life, or when you really need to lean on your care. And then you may find that you miss the opportunity to buy the supplement because you have a health issue. So Medicare Advantage is not right or wrong. We have noticed a pretty steady trend of more and more people deciding that they want to move into Medicare Advantage. This is nationally. We have noticed this with clients that we've worked with. I've done this since 2006. And back then, I would write probably 90% Medicare supplements. And so our book of business, we have about 15,000 policyholders, used to be heavily tilted towards Medicare supplement. And now it's shifted. Every year we move a couple hundred people off of supplements into Advantage plans because rates go up. Their friends have went with Advantage. They've had positive experiences. But I would just make sure that we're fully educated on how this works and how some of the challenges politically and just in our country can affect this long term, because nobody knows what that funding is going to look like in 5 or 10 or 15 years. And if it changes radically, then you may see Medicare Advantage look way different than what it looks like now, but you're older and your health may have changed to prevent you from getting out of it. And so the Inflation Reduction Act, one of the biggest things that it's doing as we approach this annual enrollment period is it is shifting the cost on prescriptions from the consumer to the insurance companies. So the Inflation Reduction Act was passed in 2000 and at the end of 22 into 23, and it reforms, I guess you would say, for lack of a better word, the Medicare drug program for all plans on both sides. So this, we can't escape this by buying an Advantage plan or buying a very expensive drug plan or a very inexpensive drug plan. And so what it is doing next year is it is adding a $2,000 max out of pocket on all Part D programs. So prior to that, we had something called the coverage gap or donut hole, which was basically everybody on Medicare got a bucket of money to spend, right? If you were on Ozempic or Eliquis, you would pay about a $50 copay, but the cost of that medicine, which is about $1,000 a month, was chipping away at this bucket. And then when you ran out of money, the consumer had to pay more at the pharmacy. And then you paid, and at the end of the year, you found that, that drug was $15,000. You paid $4,000. The insurance company paid $11,000. And some people never hit the donut hole. They were on 5 or 7 generic prescriptions that were very inexpensive, and your plan covered them for free. Tier 1 and Tier 2 drugs were just $0. And so you had this hole in your plan, but fortunately, you didn't spend enough money to feel that. Well, the Inflation Reduction Act decided that everybody needs better drug coverage. And so now after somebody spends $2,000, which the nominal user wouldn't have, they wouldn't get there. So yes, you have added protection, which certainly is a good thing, but this law really doesn't affect you in a bubble as it stands right now. But that other consumer that was spending $200,000 a year on medicine because they were on cancer drugs and biological prescriptions, they are now going to benefit significantly because under the old rules, they might have spent $7,000 out of pocket and the insurance company paid whatever else. But then next year, they're only going to pay $2,000. And then the cost difference, in that example, it's $5,000, these insurance companies have to pay. So this is the big rub, is that these insurance companies on both sides of the equation are not just absorbing that extra cost and saying, well, we'll operate at a loss. We are seeing them pass that really directly onto you. And then our industry is being affected by this as well. So we're seeing really, I guess, a couple of things. If you are on this path with a prescription drug plan, we are seeing premiums go up. Now, it's going to be plan specific, whether you have WellCare or Humana or United Healthcare. But on average, we are seeing premiums double or triple, go from $25 to $70, from $9 to $55. So for clients that maybe set it and forget it because their plan has just hovered around the rate they've been at, this year, we're seeing some pretty significant changes in premium. Now, some plans haven't done that, but it's just, I would say the trend is that a standalone drug plan is getting much more expensive to offset the fact that they have to pay more. So if you are a nominal prescription user and you're on a plan that goes from 30 to 90, I would encourage you to let's look at a different plan because there's going to be some margin there to probably justify switching. The other thing that has happened on both sides of this is that we are seeing formularies skinny or narrow. So a formulary is a tool that these drug plans use to limit cost, and it's more or less a phone directory of prescriptions. So you can look up, if I have asthma, there are 7 breathing medications that a plan over here covers. And then another plan might cover 11 breathing treatments. And another plan might cover 13. But one of the rules is that these plans have to cover drugs in every class. So they can't exclude all asthma medications, but they can pick how many they want to offer. And we are seeing that decrease. So in response to these insurance companies having to spend more, they're going back to the manufacturers and saying, look, we will put you on a pedestal, Pfizer breathing medicine. You have to discount your fees back to us. And in exchange for that, we will drop some of your competitors' breathing treatments, which will drive more traffic to you. But as a consumer, that is going to be disruptive. If you have been on a non-Pfizer medication for that treatment your whole life and it's worked great, now you may find because of this law that your drug is not on the list of the plan you have been with for X number of years. So the workaround on that, one is to shop around and go find a drug plan or a Medicare Advantage plan that does cover the drug that you need. which is if we're over here, that's one of the perks of supplemental is that your drug plan can be changed at the end of the year without answering any health questions at all. And it does not affect your health care. So if we identify that one of your medications is not on the list, we can just move you from drug plan A to drug plan B, and you still see all the same doctors because it doesn't affect us. On a Medicare Advantage plan, everything's wrapped together. So if you lose a drug or you lose a doctor, we've got to move the whole thing and make sure that the plan we switch you to because of a prescription change also has your doctor and your dentist, et cetera. So this narrowing of the formulary is it's going to be hard for the average person to quantify because sometimes you just don't know what you don't know, or you've got to kind of match your drug list to the plan. And that's a service we can provide for you. So we've seen that as a change from the Inflation Reduction Act. And then another thing that is happening is on these Advantage plans, the extra benefits that they rush to give everybody this year, like that free fitness benefit, is going away, unfortunately. So to be expected, it was crazy to sell plans that would pay for a new driver and to pay for tennis shoes. And if we really look at, we knew that wasn't going to last. I think we were kind of surprised that it was only a 1-year perk. But if we're buying Medicare Advantage plan, the way I would solve this is to not, those things are nice, but we're going to make our decision on our doctors, our prescriptions, the confidence that you have in the insurance company, the reputation the company has in our area as being, user friendly and have a good network. And then I would say the dental benefit by far is the number one benefit, extra benefit that these Advantage plans have that people use quite a bit. There's over-the-counter perks, there's free gym benefits. Those are nice, but eventually everybody has enough Band-Aids and they have enough vitamins and minerals on these over-the-counter perks. So I don't place a ton of importance on that. Everyone, is entitled to rank those things their own way. But I would say the dental benefit is another one that we are seeing regress for the first time in a few years. So if you've been on a Medicare Advantage plan for a while and it's worked really well and you get dental and vision and hearing and everything seems to be working, we may find because of the Inflation Reduction Act that those benefits either go to zero or they go from no network to a network, or some variety of little bit off the top here, limiting here, not as good as it was last year. So I would go ahead and anticipate that. And the tricky, interesting thing is that these companies know which plans are more popular and have heavier usage. So if you've been on what I would kind of call a core HMO or PPO product with United Healthcare or Essence or whoever it might be over here, what we're seeing happen is that those companies are making their older plans worse, but the newer plans that people are out shopping for are either getting a little bit better or staying the same. And so we're seeing this interesting trend where, and I equate it to the cable industry, where if you just stay on the same plan that you've been on for 8 or 10 years, you may be missing out on more dental, more over-the-counter perk, whatever it might be, because you didn't call and kind of threaten to cancel your cable and then they give you the new shopper deal. And so that's something that we can help you with, but we are seeing this pretty big shift because of the Inflation Reduction Act and how it's changing the compensation to these Advantage plans. And then the last thing I would tell you is that it looks like most of the Advantage plans in our market are going from no deductible to a $600 deductible for higher tier prescriptions. And they're changing the copay on prescriptions from a flat fee to a percentage of the cost of the medication. So ultimately, what I think is happening is that now that there's a $2,000 max, these insurance companies are saying, you know what, consumer, you need to get to the $2,000 on your own first. Then we'll pay everything else. So the 80% of people that have never had a donut hole concern because they don't take any medicine, they might have a rude awakening next year where their drugs used to be 0, 0, 0 in 20, for the last 10 years. And now all of a sudden they have to meet a $600 deductible first. And so it will feel like a bad deal. And quite frankly, I guess in that situation it is, because you never hit this $2,000 max. So this is really the first time in probably the last 5 or 7 years that we are seeing, and it shows here is that as these plans get better and better, more and more people on the fence are convinced or wooed into them because of a dental benefit or the silver sneakers or whatever it might be. And so it will be interesting to see over the next couple of years if this trend levels off or even recedes as these Advantage plans kind of relearn how to make money and stay profitable in this new environment. We're also seeing, and not so much in St. Louis, but we're seeing some plans exit service areas. More so in the South, we're seeing plans just pack up and leave counties because of these changes and this lack of compensation from the government, that they just have decided it's not worth to operate at a loss. And so if you are losing your plan, you have a guaranteed issue to come back to the table and go purchase supplemental or a different Medicare Advantage plan without answering any health questions on either of those. So I think other things that we're paying attention to because of the Inflation Reduction Act is this elimination of the donut hole, the $2,000 max out of pocket. And then there's also a smoothing program. So if you go to the pharmacy and they tell you it's a $2,000 bill, you can opt into a payment plan called the smoothing provision, where basically your prescription drug plan can cover that $2,000 out of pocket for you. And then you can pay off almost like balance billing with your utilities bill. Instead of it being really high in the winter and low in the summer, you can kind of average that out. I would stay away from this and let everyone else be the guinea pigs on how this works, because the direction we're receiving from the government and from the insurance companies is embarrassingly weak and vague and contradictory to each other. And so it's called the M3P program, but basically what you can do is you can set up your deductible or your $2,000 out of pocket as a payment plan. We can mess with that if we need to, but I would just acknowledge that exists and really is not something I would encourage people to opt into. And then the last thing that we are curious on is, for the longest time, prescription coverage through an employer was considered better coverage than Medicare. And so if we delayed, go back to those 3 doors, if I decided not to jump into Medicare because I had an HSA plan, my drug coverage was considered credible because Medicare's drug coverage did not have a max out of pocket. It had this donut hole in it. So what we don't know yet is, because of this law, are those HSA plans going to no longer have credible prescription drug coverage, which would generate enrollment penalties when you come into the system later on in life. And this was one of those unintended consequences that when the government passed this law, I don't think they realized this. And so the leadership has decided that next year in 2025, this doesn't count. And this gives us a year to kind of figure out what the rules are. And so we're curious to see what the end result is, but then also what does that do to the impact of people that are on the fence about, should I switch to Medicare or should I stay on a group plan? Well, if I'm going to have worse drug coverage on my employer plan and maybe what's called the late enrollment penalty for prescriptions, I might decide to jump in because of that uncertainty versus previous years I might have stayed on my employer plan. So we don't have full disclosure on this yet from the government. We hopefully will next year, but we'll stay tuned to that. And so what we're going to take away from this is that the prescription benefit is under a lot of scrutiny because of the Inflation Reduction Act. And this is the year to take a look at your plan even if we've been on Medicare Advantage and have enjoyed this ride of plan getting better, 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 staying the same. Because from what I have seen with renewals with most of the plans out there, we are seeing some regression in that market. And the goal is to be ready for that. Sometimes it just is what it is, right? We can't avoid it, but to not just assume that your plan has your dentist in network because it did the last couple of years. Because if you find that out after the fact, then that's tricky to fix versus that ounce of prevention and proactive takeaway. So with that, I want to thank everybody for paying attention and happy to answer any questions anybody might have.
Yeah, Carl, while we're waiting for questions to potentially come in, I haven't seen any pop up yet, but all of you described a great job, by the way. But if someone needs your help or wants your team to help out, you mentioned open enrollment October 15th through early December. When is the time frame that they should reach out to you and start to get on your calendar or someone, one of your associates' calendars?
I would say now we're actively scheduling into October, November, December, and so we can't disclose like all the substance of these plans until after October 1st. That's just kind of like Medicare's rules. But we can certainly talk to people today or set up meetings into October, November, which we're booking quickly because of the chaos that we're seeing this year. So that would be now, I guess.
Yeah. So one question that came in, I'll just repeat it. I understand that Medicare Supplement offers various freebies, gyms, over-the-counter, etc. What is the best way to find out all of the items that are available so I'm not missing out? And will these still remain on the supplement plans?
So good question. If I come back to this slide, for the longest time, all of the little freebies like hearing aid benefits, free gym memberships called Silver Sneakers or Renew Active, the over-the-counter perk. Some of these plans had flex cards where you could, more or less use a prepaid debit card to cover dental and, more or less cash. That was all reserved for Medicare Advantage. So, part of why that trend looks the way it does is that you had people that, you go out to dinner with your friends and this stuff comes up and, your buddy's talking about, yeah, I got, vitamins and supplements, and then I got acupuncture coverage, and you're over here with like, wait, well, I don't have any of that. And so most of the perks that you hear about are still reserved for Medicare Advantage plans only. But Medicare supplements did add Silver Sneakers and Renew Active, the two gym membership benefits. And that's reserved for like the AARP supplement through United Healthcare. Still gives you that perk called Renew Active. And then Anthem, Blue Cross, and Blue Shield on their supplement gives you Silver Sneakers, which is a free gym membership to participating gyms. And the rosters of gyms available to you with those two companies does differ a little bit. So that is not changing from what I have seen. Anthem is still going to offer Silver Sneakers next year. And the AARP United Healthcare supplement is still going to offer Renew Active included in their Medicare supplement plan. But to my knowledge, they are not adding any other benefits like over-the-counter or hearing aids or dental. If you want dental on this side, we need to go purchase that directly from Delta Dental, United Healthcare, Guardian, whoever it might be.
Okay, another question. When does it make sense to switch from supplement plan F to an alternative?
So good question. This market looks like this, and plan F used to be what everybody bought and we sold, and it was like the top of the line coverage. And plan F pays 100% of everything left behind by Medicare. So if you had a plan F, like you just walked in anywhere you want, everything paid for. But in 2020, the government stopped allowing new to Medicare people to purchase plan F. And they said that is too rich of a benefit. It covers first dollar. We want people to have a little bit of skin in the game. So now Plan G is the new top of the line coverage. And Plan G is 99% the same as F, with the exception of this Part B deductible, which this year is $240. So if you buy a Plan G, you pay the first $240, and then G and F are the exact same. What we are seeing, though, and we've seen this happen with long-term care insurance as well, is that you get this aging book of business, right? A Plan F group through Humana or Anthem or United has no younger, healthier people getting into it because those people turning 65 today have to go by Plan G. So what we're seeing is that rate increases on a Plan F are increasing at a faster percentage than a Plan G, with very little difference in benefit. So to answer that question, I would say as soon as possible. And not every scenario is going to be as black and white. It just depends. If you're paying $250 a month for a Plan F and we could get you a Plan G for $180, we can turn that into a math problem. You save $70 a month times 12 is $840, and you give back that deductible, you're $600 ahead. Now, the catch is that to switch from an F to a G, you would have to answer health questions. So it's not that Plan F is going away. It's been grandfathered in. People can keep it forever. But what we have seen, now we've got 5 years of experience with this law that was passed in 2020, is that the spread between an F and a G just continues to widen, and that deductible is a nominal amount.
Makes sense. Well, it doesn't look like we have any more questions. Appreciate everyone's time. End a little early unless somebody wants to jump in and ask something here before we end. But I appreciate everyone tuning in and learning a little bit more. It's a complicated space, a complicated market. So I'm always, I continue to be impressed by your expertise in it, Karl. So thank you for joining us and sharing everything you've learned and the unintended and intended consequences of that act, and then just the ongoing changes and being readily available for anyone that asks questions. So really appreciate
and I would encourage individuals to reach out. We try to get as specific as possible on some of the kind of nuances, but there's just so much stuff that makes healthcare unique to you, right? So a 5 or 10 minute chat with me will either give you the confidence to know you're in the right spot or you're not missing anything, or maybe we hit a home run for you and save you $2,500, and it's all upside, and good thing we spent 10 or 20 minutes chatting because it's a good payoff. But I'm happy to just be available for anybody who needs some help.